Good morning, good afternoon, or good evening, depending where you're joining us from. And welcome to this year's second virtual dialogue in the Cervical Cancer Elimination series. Your roadmap to 2030, inspiration for getting it right in cervical cancer screening and treatment. So we hope for the next roughly 2 hours, you will get some inspiration. We have a stellar cast of speakers. And my name is Alessandro. I'll just go through some very simple ground rules, the usual Zoom code of conduct, so to speak. But first of all, also let me thank and acknowledge Jhpiego and Together for Health, which we have developed this virtual dialogue in partnership with. So, as always, please keep your microphone muted unless you will be speaking. This session is being held as a meeting, so to enable the maximum interaction with the audience and with the participants. Feel free to keep your camera on so we can see where you're connecting from, unless there is a problem with your connection. And do open the chat box and make full use of it, as we will be taking question at allocated time, and you can start typing in your comment or questions as you hear the presentation. Today we also will have interpretation. All the presentation will be in English, but for those who prefer French or Spanish, we have interpreters that will translate into those two languages. In order to access those particular audio channels, you can simply look at the interpretation icon at the bottom of your screen, and then you can select from there your chosen language, whether it's Spanish or French. And you can decide to mute the original language so you can simply hear the interpreted language. This is also a little reminder to all our speakers to keep in mind that the session has been translated, so to try to speak not too fast, as clearly as possible, to make the job of the translator as easy as possible. And for those who speak in French and Spanish, please feel free to use the chat box and also to post your questions in those languages. We have staff available in case we will need to translate them into English when we post them to the panelists and to the speakers. So before taking too much time, because we have loads of items to go through, I just very briefly wanted to share a quick overview of who we have in the room today, all the participants that have registered. Hopefully they will all be able to join us today. This is just a few minutes before I joined the session, but I know that the numbers have gone up already. So we've had 278 registration from 58 countries, and those you can see are marked in that map on the left, so very wide coverage across the globe. But I always also wanted to highlight the diversity of the organizations represented today, which it's a hopeful testimony of the true intersectoral nature of the movement interested in the elimination of cervical cancer. So without any further ado, though, let me pass the floor to our MC for the day, who's Maura McCarthy, the Director of Partnership at Jhpiego, who will quickly guide us through the agenda and introduce the first speaker. Over to you, Maura.
Thanks so much, Alessandro. So as Alessandro said, my name is Maura McCarthy. I am the Director of Partnerships at Jhpiego with a special focus in women's cancers. And it's really my pleasure to welcome you here today to our event, Your Roadmap to 2030, Inspiration for Getting It Right on Cervical Cancer Screening and Treatment. So thank you for being with us today. As Alessandro showed that slide, it's really impressive to see that so many of us have joined from all over. I think, that's really indicative of the enthusiasm and momentum we all feel towards eliminating cervical cancer. This is the second event in a series of virtual dialogues hosted by UICC and Jhpiego on the elimination of cervical cancer. And I think the focus today on secondary prevention will really tee us up nicely to build on insights shared today at the World Cancer Leaders Summit in October of this year. So as you can see from the agenda slide, we really are grateful to have some wonderful panelists with us today to lend their insights and perspectives on what it'll take for us to collectively achieve our global cervical cancer elimination goals in 90-70-90 targets. And I think really focused discussion today on secondary prevention, what it will take to achieve national coverage of screen and treatment services, what are some barriers and key gaps, how will we understand where we are at in progress towards our elimination goals. And I think, really exciting, we will also have a sneak peek at some forthcoming guidance for us on screen and treatment guidance coming from WHO, as well as some new costing guidance on secondary prevention services. So we have a lot to cover. As Alessandro mentioned, please make good use of your chat to add to the richness of our discussion. And I will turn now to our first segment. And Alessandro, maybe if you advance the slide, great. So it is my pleasure to introduce, though for many of us, he really needs no introduction, Dr. Groesbeck Parham. Dr. Parham is an honorary professor at the University of Zambia and a board certified gynecologic oncologist. Dr. Parham was an early leader in scaling screening and treatment services in resource-constrained settings for women living with HIV in sub-Saharan Africa. Dr. Parham sits on the Cervical Cancer Elimination Initiative, serving as special advisor to the Assistant Deputy General's Office, and he's lived and worked in Zambia since 2005. So really pleased to be able to pass the microphone to Dr. Parham. Over to you. And Dr. Parham, perhaps you're on mute.
Thank you so much. I'm leaving my video off to enhance my reception here, but thank you so much. I'm on mute. I'm on. Hello, can you hear me?
Yes, we can
Can
hear
you
you.
hear me now?
Yes, Professor, we can hear you. Can you hear us, Professor Groesbeck?
Oh, that's a shame.
Yeah.
Yeah.
Okay.
Hello, can you hear me?
Yes.
We can.
Okay, good. So thank you. I said I was turning my video off to enhance my reception, and then the whole thing just clicked off. But anyway, thank you so much. I'm honored to be a participant in this, a facilitator. And just so we just keep moving right into things, we had two speakers today to start off the virtual discussion, but Dr. Leanne Riley could not participate. She had some other things arising. So we have our great friend and colleague and leader that we all know very well, Dr. Natalie Boutte, who is going to give us a preview of and maybe hopefully a more in-depth discussion on the new WHO guidelines on cervical cancer screening and treatment with special emphasis on women living with HIV. So without further ado, Natalie, the floor is yours.
Thank you, Groesbeck. Thanks for this introduction, and thanks to colleagues in Jhpiego and UICC for the invitation. I think it's a great opportunity to share with you some of these recommendations and to start the discussion on the implementation side of things, which is really what we need to address. I will focus really on the work done around the elimination and also on the targets, I mean, how we can reach the targets for the framework. So the next slide, please. So you remember, and you all know now, that in 2018, the WHO Director General launched the idea of elimination of cervical cancer to address the inequity really that we see in cervical cancer incidence across countries and within countries. And then we developed the WHO Secretariat developed the strategy framework, which is here, and that is around the 3 key targets by 2030. But the bottom line and the threshold that we determine as elimination threshold is that each country should reach the age-adjusted incidence rate of 4 cases, less than 4 cases per 100,000 women a year, and that before the end of the century. Can you go back? So to reach this threshold by the end of the century for each country, and that's all the modeling work which was done, we need to reach this target of 90% of girls fully vaccinated, 70% of women screened twice in a lifetime with a high performance test, and 90% of women detected as positive or with a cervical lesion needs to be treated. And you can imagine that these targets are quite challenging, but not infeasible. But we really need to work a lot to reach to the 2030 targets of principally of screening and treatment. The next slide. And to give you the idea of the challenge that we're going to face, or we are facing right now, is actually at the moment, this is the work we just finished with the Institut Catalan de Oncología, WHO and HRP, on the estimate of screening coverage of women aged 30-49 years by countries. This will be published very soon, so I will not be able to share the slides because it's not published yet. But in a nutshell, we have 76 countries. These are the green and pale green one that have achieved already the 70% screening coverage. And all the other countries, 126 countries have not achieved. And some of them, as you can see in dark green, are below 9%. So this is really the magnitude of the work we'll have to face to ensure that we have 70% coverage. The tests that are used as really high performance tests so that the programs are effective and cost effective. The next slide, so that's the reason why we decided also, I mean, one of the reasons that we decided to update the guidelines for screening and treatment and to have maybe simpler algorithm that will facilitate to reach this target. We are also establishing a living systematic review on screening and treatment that will allow us to really issue recommendations as we have new evidence coming out. So we have tests that we have not looked at yet for these recommendations, like the automated visual evaluation or oncoprotein test, because we don't have enough evidence, but we are watching this evidence coming out. So the next slide. So basically we have 3 different ways of screening. So we use molecular tests, cytologic tests, and visual inspection. In these guidelines, we looked at HPV DNA, HPV mRNA tests, conventional pap smear, and VIA. In this one, we have, I'm not going to present on mRNA yet, because we are just finalizing the recommendation, and it has to be submitted yet to the WHO Guideline Review Committee before I can share the recommendation with you. So the next slide. And so the recommendations are really about the different strategy. And we looked at which strategies should be used in terms of a screen and treat approach. So it's a treatment following the result of a screening test, or screen, triage, and treat approach. As a primary screening test, we looked at HPV DNA, but we looked also at VIA cytology. Triage test, we looked at VIA, colposcopy, HPV 16, 18, and cytology. And of course, we haven't really reviewed the treatment recommendation that we have just finished with tablet ablation. And we looked also at the follow-up after a positive or negative test, the age at first screening, and principally for women living with HIV, because we didn't have a real recommendations, the frequency of screening, and the treatment recommendation. The next one. So the source of evidence that we use is quite diverse. At the same time that we were doing the recommendation, IARC, the International Agency for Research on Cancer, was developing the handbook that looked at all the primary study on screening. We also included published systematic review. We looked at the diagnostic accuracy of tests. For the age at first screening for women living with HIV, we did an individual patient data meta-analysis. We did modeling, and Karen Cantwell is with us today, and I really want to acknowledge the work that her team did for this recommendation. And they did all the modeling work for impact and cost effectiveness. We did specific surveys on values and preferences for the end user and for women. And we did a short survey on implementation challenges. So all that, we used all this evidence ready to do the recommendations. And the guideline development group discussed, reviewed the evidence, discussed the evidence with the methodologies, the systematic reviewer, and we agree on what could be said and how to say it. The next one. So altogether, we have 22 recommendations and 6 good practice statements. So for each of the group, for the general population of women and for women living with HIV, we have 11 recommendations and 3 good practice statements for each of them. The next one. And this is really the most, I would say, the most important recommendations all over, and really the key message. So based on all this evidence and the discussion with the guideline development group, we have 2 different types of recommendations. For the general population of women, we really suggest and recommend the use of HPV DNA as a primary screening test. And then it can be either a screen and treat approach, so direct immediate treatment based on the screening test, or a screen, triage, and treat approach. And then for the triage test, it can be cytology, VIA, or HPV-16/18 or colposcopy. For this general population of women, the screening should start at age 30. It has not changed. And the screening interval of maybe 5 to 10 years. And for the woman living with HIV, is slightly different. Though the screening, the primary screening test recommended is the same, HPV DNA. But then for women living with HIV, we recommend screen, triage, and treat. So we will not recommend the screen and treat approach. So we need to have a triage test. The age at first screening will be 25, and the regular screening interval will be every 3 to 5 years. The next slide. So this is really important summary of the recommendations. So in a word, we're really encouraging countries to switch from cytology or VIA-based program to HPV DNA-based program. And again, it can be HPV without triage, immediate treatment, cryotherapy or thermal ablation, but not for women living with HIV, and HPV testing plus triage, HPV-16/18, VIA, or cytology or colposcopy for both population of women, the general population, and women living with HIV. The next slide. We have also an important recommendation that we believe is going to have an impact on the coverage, is the use of self-collected samples for HPV DNA. So that will be, it's the strongest. We had this recommendation before, but we have more evidence, and this is a stronger recommendation than it used to be. Next slide. So to achieve the 70% coverage of screening and the 90% treatment of precancer, we need some strategic actions. Then the first one is really to national scale up, the scale up of screen and treat, and screen, triage, and treat. So we need really to introduce this algorithm in countries. It can be chosen by program manager between the screen and treat approach and screen, triage, and treat approach. It can be several algorithms in the same countries, but it needs to be very well planned. The next slide. And I just want to show, we're speaking at the moment of HPV DNA test as a high performance test. But if you look at this map, which is also from the same work that I was mentioning at the beginning, you can see that very few countries have introduced already HPV DNA. Australia is one of them at scale as a national program. Many countries, and these are the ones with 2 colors, they have both HPV that are transitioning, in fact, from either VIA or pap smear to HPV. But as you see, many countries are not transitioning, and they are still using pap smear or VIA. And many countries also, there is no official recommendation. So that's beyond the coverage. That's what really we need to understand, this magnitude of the issues and how we're going to support the introduction of this test in country. Next slide. And then that links to the other recommendation for achieving, the actions, the strategic actions to achieve the 70% coverage is increase the quality and coverage of service delivery. So let's be creative about integration of services, patient retention, so we ensure the treatment of patients screen positive. And we need to have sufficient, affordable supply of screening and treatment technologies and products. We need the prompt certification of new products, either by regulatory agencies, but also by WHO pre-qualification system. And we need to also to introduce a price reduction strategy, because we have a really long way to go before having this test affordable for all countries. And finally, we will have to monitor progress, and monitoring framework and be in developing for this purpose. Next slide. These are all the colleagues from WHO and IAC with who we're working days and nights to get to these guidelines. And I want to thank them a lot. And the next slide. And although I must say that we have quite a number of challenges in front of us, that's okay, and cervical cancer. Thank you.
Thank you, Natalie, for a very fascinating presentation. We have some great questions for you, and I'm going to just rattle them off, and then you can get to them. The first one has to do with the use of imiquimod in low resource settings for the treatment of pseudo-white lesions that are too large to be treated with ablation. And I would think this may be applying to women living with HIV who tend to have these very large high-grade lesions. How is it applied to the cervix? Can the patient apply it? Must it be applied with a speculum? What is the frequency of application and duration of treatment? And following treatment, must LEAP always be done, or can you just follow the patients? Here's another question. What is the rationale of not applying screen and treat in women living with HIV? We thought we should be aggressive and treat all who are HPV DNA positive. And then the last one is, will the recommendation for HPV self-sampling include urine? So let's do the imiquimod, and then why are we not applying the screen and treat approach to women living with HIV? And then the issue about self-sampling, including urine. Please, ma'am.
Okay, thanks. So
did you hear me?
First question, can you hear me? Yeah. The first question on imiquimod treatment. Yes. So we haven't recommendations on that treatment. We recommend it for the treatment of genital warts for sure, but not for cervical intraepithelial neoplasia. Not yet. And maybe we should look at the literature, but what we've seen at the moment from the literature, there is not really constant effectiveness or constant finding on effectiveness. There is a lot of pro and cons on and we don't really have big clinical trials that have shown the interesting results. It may be promising. It may be promising, maybe not as a cream, or maybe not in the formulation it is at the moment, but immunotherapy is certainly something we need to look at in general. And we are working at the moment on development of HPV therapeutic vaccine. And this is why, this is a promising technology, but at the moment, we're not recommended it, the imiquimod treatment or cream for the treatment of CIN. How it is used, it's a cream, and in the randomized control trial that have been done, it's I think it's 5% imicromine cream that is applied to the cervix using a speculum and with a little, how it's called, something to apply the cream. It has been done in the context of trial. It's not recommended outside the trial at the moment. So, and you know, the application that was done in trials was weekly applications during 12 weeks. So it raised also concern of the compliance of the treatment, which is not easy, as you can see. And there is also some safety issues related to pregnancy. And you know, in this 25-year-old woman or 30-year-old woman that becomes pregnant in these 12 weeks of application of treatment, we don't have, there is a lot of some signals that it may not be safe for pregnancy. So that's not something, I mean, you see there is an opportunity. There will be certainly lots of work to be developed in this direction, but at the moment we are not really yet where we should be. So the other question was about triage.
HPV. What about yes, for women living with HIV.
Yeah, you're right, and it's true that we've said that a lot, and I mean, I even said it a lot, and I would have loved to see that as a recommendation. But the fact, and even Karen can speak on that, because when we looked at the modeling, the number of treatment for women living with HIV, the number of treatment that had to be done to really get an impact was enormous. And in terms of human resource, cost of the treatment, it was not really cost effective to have this approach for women with HIV. Maybe when we have a more specific test, and that's why we looked at other tests more specific at the moment, it will be possible. But with HPV DNA in particular, it's really not for us to have this approach. And we prefer to have it's more cost effective to have a triage with VI or with cytology or with 16-18. What we took also into consideration is that's where these different sources of information and evidence is important for developing recommendations, is because we also looked at service delivery. And it's true that in many countries, women living with HIV who have access to antiretroviral therapy really go to services, and they are quite well followed. So the risk of losing women in this population may be less than in the general population of women, but the numbers are different also. So that's different recommendation that we need to have in mind when you do this recommendation. Again, we are looking at more specific tests that may allow immediate treatment after a positive screening test. And I can't remember, I know the urine test, right? The self-collected, no, we don't have recommendation yet on the self-collection of urine. We have not validated the performance test based on urine. Yeah? Rosbeck, you were saying something?
Okay, you just answered the question? Yes, you just answered the question about urine, HPV testing in urine. I didn't hear you. Did you answer that?
Yes, I just said that we have not recommendation yet. We haven't evaluated the performance. We need to do all the accuracy of HPV test in urine before doing the recommendation, and we have done it.
Okay. So here's another question for you, Natalie. What are the key milestones in time of every 2 to 3 years that should be achieved to benchmark the progress at regular intervals and thereby aid in reaching these expected goals in 2030? What are the key milestones that should be measured every 2 to 3 years to benchmark progress? Can you make any recommendations for those?
Yes, so what we looked at what we put in the modeling work when we developed the strategy, it's really progressive. So it will be what we think that countries should be doing and what we looked at is really to reach 30% by 2025, 45% by 2028, and then get to the 70% in terms of screening coverage by 2030. So like a progressive approach, so that, because we know it will be impossible that to reach the 70% right away, that there is a lot of work to be done. The 30% may be feasible, principally in the countries that have already started and that have that are around 10% screening coverage. Globally, we would recommend 30, 45, 70, but of course it will depend really on where the starting point is in a given country.
Okay.
And again, I want to emphasize the importance of working as a community on the availability and the affordability of HPV tests. This is really in our agenda, and this is the thing that will allow countries to be able to procure HPV tests. Thank you.
Okay. Well, we want to thank you for a very interesting presentation and QA session. And I think it's, I've been told by the head facilitator that we should move on to the next group of panelists. Thank you so much, Natalie. It was very interesting. We look forward to the release of the guidelines. I think it's later today. Is that correct?
No, it's on the 6th of July.
Okay, I'm sorry. Okay, all right, my mistake.
It's being laid out at the moment, and we'll have the launch on July 6th. So hope everybody will be with us.
All right.
Thank you very much.
Thank you so much. And back to, who is it? Back to Julie or back to?
I can take it from here, Dr. Parham. Thank you so much, and thank you to Natalie. I think we'll all look forward to the 6th of July. And I think now, in the interest of time, I think we can head straight into our second panel, which is on elements that are critical for flexible program services as flexible program services are incrementally scaled up. And I'd like to introduce the co-moderators for the panel, Dr. Julie Tarodi, Director of Special Projects at UICC and a leading advocate in the Global Cervical Cancer Elimination Initiative, and Dr. Sumesh Kumar, my colleague at Jhpiego and Senior Director of the Global Solutions and Innovations team. Over to both of you.
Thanks very much, Moira, and thank you to our panelists. As you can see from this slide, we have a great selection of experts from different parts of the globe to discuss with us today. So we'll move on quite quickly, and I'll move to our first panelist, Professor Karen Kahnfeld. Karen, we've mentioned your modelling work earlier. You've worked on the estimates that have really laid the groundwork for the pathway to elimination, and you've also worked alongside the guideline development group on HPV screening and treatment. So what is the modelling really telling us here? What can countries learn from that as they plan for 90, 70, 90? What are the key messages you'd like to share?
Thanks so much, Julie. So I have a few slides, Alessandra, if you could just move it forward. So look, I think it's, in terms of setting the scene and how we will actually be able to understand the importance of reaching the elimination targets, the 2030 targets, the 90, 70, 90 targets, I think modelling has played a very important role. And I guess it's one of the tools that we use to help leverage and garner political support in countries. I think there's a different levels of granularity in which we've done the modelling. So at the first step, we've actually done what's on the screen in front of you, which is this very large-scale global modelling picture of the impact of different types of strategies and how quickly they will reduce cervical cancer mortality rates. So this slide simply shows you, if you look at the top, the status quo through the century would be maintaining a very, very high cervical cancer mortality rate if we don't scale up on any of the triple pillars. And on the right, you can see there in the orange, yellow and blue, the options for vaccine-only strategies. And the key point here is that the reason we're not recommending vaccine-only, although many stakeholders ask about it, is that the vaccine only would really not start to reduce mortality until around 2040 or even later. And so it's really scaling up screening and treatment that are it's the critical step to accelerating elimination and accelerating the impact on lives saved. And you can see there in the purple and green, the impact of the WHO triple elimination strategy would actually let us reduce those mortality rates by a third by around 2030. So if we just move on, I think Alessandro, if we just move to the next slide, thanks. I think the other thing to make the other point to make here is that modelling as a tool is actually critical to building the investment case overall for elimination and also to support individual countries, and really just to drive home that that scaling up to these targets may seem challenging, but it's incredibly cost effective. There's an incredible investment case. It will be cost effective even in LMIC. And there's an incredible case for a return on investment, which is over $3.20 US for every dollar invested, and more than $26 if we take into account the broader societal impact. So that's really something that we need to, I think, figure out how to convey and strengthen our messaging on to countries as we move forward in garnering political support for elimination. Next slide, please, Alessandro. So just to talk very briefly about Australia, because it is used as an example, I think one of the key points in talking about Australia is, and many of you will know here, it is positioned to be the first country in the world to achieve elimination, and this is projected to be by around 2028 at the earliest, potentially up to 2035, but either way, very much in the near term. But the key point here to make is that the key step that Australia has taken to achieve this is the switch to HPV screening. This is the accelerator. This is going to be the game changer to get Australia to the elimination point. Next slide, thanks, Alexandra. And I think if we think about the factors that have helped garner this political will, it's the modelling, both at that high level that I just showed you, also the detailed guidelines modelling that's really helped understand the pathways for HPV-based screening, and also helped understand that that rapid acceleration effect of moving to HPV screening. It's the accelerating input of new technologies, the availability of HPV testing, and now of self-collection, and it's been recently announced that Australia will recommend the option of self-collection to all women going forward, and we hope that will come in from next year. It's been the advocacy and the role of civil society in supporting these changes, and it's been involving multiple stakeholders. In terms of monitoring and evaluation, I think it's really critical that countries consider, just going back, thanks Alessandro, consider the important role of monitoring and evaluation, and we were really pleased to launch Australia's first national report reporting progress towards elimination, and really calling out progress at several levels of indicators, but also even in a high income country like this, the data gaps and needs going forward. Moving on, thanks Alexandra. Next slide. So keeping in mind as well that I think we need to keep our eye on the ball, even in the context of COVID. Again, we cannot emphasize enough the importance of scaling up screening and doing it in a timely way before 2030, because every year that there's a delay, there is this over 340,000 unfortunately deaths estimated. Next slide, please. Next slide, please. Next slide, please. So Professor Yingling Wu will talk in a minute, but I think again, really important to talk about the country level modelling, and she will talk about Program Rose in Malaysia, which is really leading the way in delivering a triple pronged strategy, if you like, for HPV screening with self-sampling, HPV testing supported by a secure digital e-health platform. And working with Professor Yingling Wu and her team, we've been able to show that at a country level, this will be highly cost effective, even taking into account the establishment of the new e-health platform. So I think this important role of country level modelling to support these changes is also important. Next slide, please. And just as Natalie mentioned, I think modelling is also playing an important role at the more granular level of defining all the pathways for screening and treatment in the WHO new guidelines. Next slide, please. And also it will help us build, I think, the case again at a country level, so that countries can understand that the potential for lives saved is very imminent and is very localized. And this is an example of some UNFPA funded policy briefs that we've been involved in that have been developed. And this is an example for Papua New Guinea, showing the lives that can be saved in the short term through the 3 pillars and in the long term, and showing that in one country, even in Papua New Guinea, for example, 150,000 deaths can be averted by scaling up at the appropriate level. Next slide, please. And finally, just to finish, I think there is an important role that should be taken into account for countries that are on track to achieve elimination, to support other countries at a regional level. And I think it's, I've been delighted to be involved in a first of its kind humanitarian effort to eliminate cervical cancer in the Western Pacific, which is supported by a range of stakeholders in Australia and in the region and in countries. But it will position 2 core settings, Vanuatu and Papua New Guinea, on track for elimination, and set up a range of core support facilities in the Western Pacific, including modelling, data monitoring, evaluation and registry support to enable other countries to also tap into this infrastructure. So I'll finish there. Thank you very much indeed. Back to you, Julie.
Thanks very much, Carolyn. I hope advocates that are at the start of that journey can see how strong a contribution you can make to shaping the progress in a country like Australia. You still have to advocate hard to get that important investment, but also showing how much that can change the trajectory of this disease. I've just added a note to the chat because we can certainly share links to the 2 resources that Karen shared. I think they're worth a read to really get some learnings from this great progress that Australia is making. Rosebeck, are you on or have we lost you? I know you're in the more remote regions of Zambia at the moment. Are you on? Okay, I'll hold off my question to Rosebeck until he's able to rejoin. I'll hand over to Samesh to take us through with a couple of our further panelists. Over to you, Samesh.
Thank you, Julie. So I'll ask my question to Ms. Nemi from Namibia. Ms. Nemi, can you hear me?
Yes, we can hear you. Let me apologize that we just turned off the video to ensure that our network connectivity is a little bit stable.
No worries at all. Thank you so much for joining. It must be late in Namibia, late afternoon, early evening. So Ms. Nomi Shupala is the Director Primary Healthcare at the MOH in government of Namibia. And Ms. Nomi, my question to you is that I know your government has done a great job at introducing new technologies, especially thermal ablation throughout the country, and it's in the process of scaling this up. And you also have plans for introducing HPV testing in your country, and that puts you absolutely in line with the WHO 2030 target goals of 90, 70, 90. So having heard both Nathalie earlier and Karen just now, do you think it is feasible for ministries to plan for the creating a goal or a roadmap for 2030 for 90, 70, 90 on the, especially talking about secondary prevention, the 70% goals? Is it possible to create that roadmap and a costed plan? How do you think the ministries can approach this this aspirational goal that WHO has set up for the in consultation with the entire global community?
Thank you. I was just trying to switch on my video. Anytime again, is if I see that the internet is fluctuating, I'm going to switch to the audio. But let me thank you once again for granting Namibia this opportunity to participate in the panel. And in fact, in the last few minutes, we have also learned a lot. In terms of our approach, we have beautiful and successful lessons that we have learned from the HIV program, where Namibia has progressed quite well and rapidly in terms of achieving the UNAIDS target of 90-90-90, of which we have surpassed some of them, and we are now geared toward the 95-95-95. It's the same lesson of implementation that we have to copy the lesson learned from HIV into the cervical cancer prevention. In terms of the primary prevention, as you have mentioned, the private sector is implementing HPV vaccination for the young girls, of which it's already included in the national guideline for cervical cancer prevention. It's a matter of finding the resources for implementation. In terms of the HPV testing, testing is also available in the private sector, although the cost is a little bit high, but there have been some engagement and dialogue in country on how we can achieve or foster some partnership, either with the local partner or international partner, to introduce the HPV testing in the country. In terms of, apart from the HPV testing, yes, the see and treat approach is already implemented since 2018. And a good number of women, especially those at risk in the HIV clinic, has been screened. There is a dedicated program with dedicated staff that have been recruited through the support of CDC and PEPFAR and implemented through the Jhpiego program. And that has been very successful. And now we are kind of expanding to primary care level at the health centers, high volume health center, to see how this could be further implemented. We have also been discussing in terms of doing the mobile screening, using the mobile van, because you know the whole issue with screening is access and availability. You see, women in town are very likely to have access to screening, but women in the deep rural area might not have access. And if the service is still only offered on mobile basis, so it will not be available throughout, and they might miss out. And these are the women that we are very likely to see at the hospital with advanced cancer that will require some time for treatment. So the approach really for us is we are approaching this in an integrated manner, whereby we want to integrate, or we are integrating this into existing services, either in the HIV clinic or in the general care. But the bottom line for us, we see this goal are achievable. It's just a matter of us to cement our elimination roadmap for the country. Maybe I can end there, but I can respond to further question. And I'm sitting here with my colleague from the head of the reproductive health program, as well as one of our OBS and gynae medical officer, who is really responsible for a lot of the cancer treatment at the referral hospital. Over to you.
Yeah, thank you, Ms. Nemi. There's a, I'm so excited by hearing your perspective on your that the 2030 goals are very much achievable, and it's just that we have to put all our efforts and energies into that. So that's such a powerful statement for me. There's a question from in the panel for you. So when you talk about integration of cervical cancer into the HIV platforms and other FPRH platforms, the question is, are you also building on COVID-19 testing, and what about vaccination?
Thank you. Yes, Namibia has got a service integration policy for integration of HIV and reproductive services. Wherever we have a primary healthcare clinic providing antenatal care services, in that clinic they provide HIV testing and treatment. And also in that clinic, they used to provide pap smear. Now, when we are transitioning or transitioned to VIA for those eligible women. It's provided mainly in the HIV clinic, but that is what we are also integrating at this primary care center, where women are coming for services, including family planning services, where the providers are very likely to ask questions and make recommendations for cervical cancer screening. In terms of the opportunity provided with COVID, you know, when we diagnosed our first index case here in Namibia, the 13th of March in 2020, we have to collect the sample and send it to South Africa, and we have to wait for days to get this result. But the pandemic has triggered the country to set up the local capacity for testing. As we speak now, all the testing for COVID-19 is happening in the country, and it has been decentralized to peripheral level, where samples are collected, and we are even moving into rapid testing, which is available. We even have drive-through for COVID-19 testing. Through our local university, the School of Medicine, we are now preparing to set up genomic sequencing testing for COVID-19. This capacity is being built for COVID, but these are platforms where we will start from when it comes to HPV testing. So that is what I was referring to.
Thank you. Thank you, Ms. Naimi. So I'll move on to our colleague from Nigeria, Dr. Deborah Bitrus. Dr. Bitrus represents our National Cancer Control Program in Nigeria. Thank you, Dr. Deborah, for joining us. Can you hear me, Dr. Deborah? Just confirming.
Yes, I can hear you.
Okay, thank you. Thank you so much. Thank you so much for joining. Dr. Deborah, my question to you is: Nigeria was one of the first countries to develop a beautiful costed program for cervical cancer control from 2017 to 2021, and it has, of course, with support from WHO, and it has very well, in a very articulate manner, listed your goals and costed all the three components of the prevention program: primary, secondary, and tertiary prevention. So now that we are in the final year of that program, can you talk through your experience of implementing that strategy? And for colleagues who have not seen that document, you can just Google. I'm sure you'll get it. National Strategic Plan for 2017 to 2021 for Nigeria. Dr. Deborah.
Yes, thank you very much for the opportunity. Nigeria has indeed shown a good political will towards the fight against cervical cancer, which is evidenced by that plan that was developed for 2017 to 2021. Subsequently, WHO and CHI helped us to cost the plan, and then we're now able to know where the priority areas to put attention on in order to expend the resources and provide the services needed. The plan was that by 2020, we would have reduced the burden of cervical cancer by 1/3 of its level at 2015. And that will be through screening of women at least twice in a lifetime, and then 2-dose vaccination with HPV for the eligible children 9 to 13 years in the first year, and then integrate the vaccination into the national immunization schedule, so that at 9 years, each girl child will be immunized with a HPV vaccine and be fully immunized. This plan has been pivotal in helping us to highlight areas of priority planning. But the experience in the implementation has been eye-opening and very challenging. it exposed the need for more speed. We need more speed, finance, awareness, and coordination among all stakeholders in order to implement the plan successfully. So by review, there were constraints that prevented us from achieving the targets that we set out to achieve. And these constraints include, like I mentioned, poor financing, poor coordination with all relevant stakeholders, especially at the state and local government level where implementation is supposed to be centered. Then there is this poor awareness of this plan by stakeholders, both in the public and the private sector. And then we needed to put in more equipment in place, train health workers before we could do anything meaningful to achieve this plan. And then worst of the scenario is that the costed budget has not been included in the national health budget. And that was a very big constraint because finance now became an issue. We knew what to do, and but we did not have the wherewithal to do. In spite of all this, we set out to do what we could do. And in terms of what we are now for primary prevention, we had planned to vaccinate 80% of girls between 9 to 13 years by 2020. But vaccination for HPV had not been introduced in the routine immunization schedule in Nigeria up to now. The modality we had between the Federal Ministry of Health, National Primary Healthcare Development Agency, and Gavi has not come to pass because of so many factors, of which COVID-19 played a key role. But currently, we are working hand in gloves with the three organizations so that before the end of this year, we will introduce the vaccination into routine immunization in Nigeria. And then we have pockets of organizations that provide HPV vaccines, but mainly in the private sector. And for secondary prevention, we had planned to increase screening coverage of eligible women by 20%, 80% by 2020. I want to say that the FMAH is currently working in collaboration with United and Child on a cervical cancer secondary prevention program. This program targets to screen 430,000 women in 2.5 years' time. Although there was a delay in commencement, but the program has commenced this January. And it is in 3 pilot states in Nigeria: Lagos, Kaduna, and Rivers State. So far, we have trained 1,250 healthcare workers to be involved in this program, and we have already screened 50,000 women. And what we are looking at is that we will upscale this after we have learned our lessons and experiences from these 3 states that we are piloting now, and then upscale it into other states in Nigeria. Thank you.
Thank you, Dr. Deborah. I think it's a great example of leadership by government and support from partners, United, Chai. So compliments to all of you. My follow-up question on and I hand over to you, Julie. I see you looking at me. Is are you planning to extend this costed plan into beyond 2021, a follow-up plan for 2030? And if yes, you know, what is the plan for that, and what kind of you know, modeling support or any other tools and resources? I think do you think that the government FOMH will need? Because I asked this question because as this is applicable for Nigeria, it's also applicable for other countries who are interested in developing that that roadmap for 2030.
So yes, we have on that question, we have already started discussions within the National Cancer Control Program, WHO and CHI. We have already started discussion to update and extend the plan in order to meet the goal of eliminating cervical cancer as a public health problem in Nigeria. The first meeting on this will commence on the 24th of this June. And then subsequently, what we plan is to use evidence-based findings in order to update the current plan to meet up with the goal. Now, for HPV DNA testing, we have integrated the HPV DNA at 3 mega labs in Nigeria. And we have, the mega labs are located in Kaduna, Rivers, and Lagos State, where the screening program is taking place. Then we also have 11 gene expert machines that are now testing HPV samples in Lagos, Kaduna, and Rivers. Super. So, but the modeling that was used for this plan that we have was sponsored by the World Health Organization. And they used the cohort model to estimate the mix of interventions that will produce the best outcome at the lowest cost, taking consideration the constraints that we have in Nigeria, including finance, hard to reach populations, and other coverage rates that are low. Everything was taken into consideration to bring out the modality that we have adopted, which is to screen women 2 times in a lifetime, and then give 2 doses of the HPV vaccine to the eligible population. So we will use the same system, and we will get to you so that you will help us to assist us in this modeling, so that because of the constraints we have, it will be taken into consideration, and a best model will be optimized and then provided for us to use.
Oh, thank you. Thank you, Dr. Deborah.
Thank you.
I hand it over to Julie back. There's a question on engagement of community CSOs. Maybe we'll take it on later in the conversation. Julie.
Thanks very much, Sumesh, and thank you also to our speakers from Namibia and Nigeria. I mean, I think we hear that there's some progress, but also a big area for advocacy in both countries. I might just add also that the WHO supported modelling at country level. I understand that WHO was happy to try and help other countries model in the same way as they've helped Nigeria. So if you want to advocate for that in your country, WHO is very willing to try and help where possible.
Thank you.
So I would like to move now to Rwanda and Dr. Francois Unvinkindi, NCD Division Manager at the Rwanda Biomedical Center. Welcome, Francois. Are you on, Francois? Can you hear me?
Yes, yeah. Thank you, Judy, for coming.
So, Francois, I'm excited to see the progress being made in Rwanda on extending screening now to a number of provinces. So could you give us a short description of what helped, what the factors that really helped facilitate this first step towards scale up? And have you got any early learnings that you can share with our audience?
Okay, so thank you so much, Julie. So I would say that we initiated cervical cancer screening back in 2014. But at that time we were using a VIA-based screening strategy. So, and then in I think we started in March 2020. That's when we started the introduction of HPV DNA test. So it was a support. I mean, it's a project being supported by CHI through a funding from United. So where we intend to screen around 72,000 women in 5 districts, so that we can get more, let's say, knowledge and skills on how we can now better integrate HPV DNA testing into our, into our cervical cancer screening program. So, and I think since then, so the new strategy is to, of course, we are using HPV DNA, I mean, molecular platforms that are already existing in hospitals. There are those molecular platforms that are used to do HIV viral, hepatitis viral, and also the same platforms that are being used for COVID-19 testing. So we have also moved the treatment of simple precancerous lesions at the epicenter level, where we are providing thermal ablation devices to all those health centers that are providing the training. So the sampling is being done at the health center level, and then samples transported to these city hospitals where those molecular platforms are for testing. And then we have also built the capacity for these city hospitals to be able to treat you free for those women with advanced precancerous lesions. And then the key thing here is, again, so in order to have sustainable programs, we're integrating screening programs to existing services at the facility, mainly focusing into HIV and also maternal child health services. So again, we're also involving the community health workers for demand generation and also follow-up. And also another like new change that we have introduced. So we are now using electronic medical record system. So where those healthcare providers have got tablets with this electronic medical record system. So doing real-time data collection. So the same tool is helping us in tracking the movement of patients. So, and also make sure that really we have an eye on the referral process of those women that we are referring from one facility to another. So basically, because since the beginning, so we've been able to screen around 22,000 women with HPV DNA test. So like the program is being now implemented in 62 health facilities. So we trained around 552 healthcare providers, 2,500 community health workers. So if you look at the data we have now, so the positivity rate for HPV is in around 20%. So, and also we have been just in this process of tracking the movement of patients. So the referral completion rate is around 84%. So meaning that there are still 16% of our women that we are not able to, to make a good follow-up on. So like summaries on rant now, it's like, so in order to have these programs like being scaled up, being sustainable, should have like a high political will and support. So, and what we have seen also, there is a high demand and also acceptability from the community. So, and also integrating these services into HIV and also maternal and child health services, it's very helpful. And then you can even get some funding from those programs, which are somehow well funded compared to our programs on cervical cancer, but also on NCDs. And then, so with this new program, the thermal ablation is being done by, by those nurses, and so far it's really safe. We didn't really meet with any serious adverse event. So it's a technique that is safely done by nurses. And also having this digital tool is helping us a lot in doing like the follow-up, the tracking of the movement of our women. So, and then what we also have seen, the self-sampling appear to be the preferred, like say, sampling option by our women. So most of them, they would like to do self-sampling, and then having really our partners involved, but also other sectors involved. Really, it has helped us really to reach out to, many women and also be able to move forward. So, regarding some challenges that we have seen now, just with this, after 1 year of implementation of this new cervical cancer screening strategy, is that really, so we don't have our own molecular platforms. We're using those platforms being used for HIV, for COVID-19, and also for hepatitis B and C, viral load. So meaning that there is really this competition with those other programs, so that, that is bringing like some delays in getting the results to our women. So the turnaround time is, relatively high, like 1 to 2 weeks to get the results back to the health centers. So, and then, you know, I mean, we don't have dedicated nurses and dedicated providers for this cervical cancer screening program. So, I mean, we're using the same nurses providing other services at the health centers. So there is also these competing priorities at the health facilities. So sometimes also because, you know, we take samples at the health centers, we send them to the DCT hospitals for testing. So, and then once the results are back, we call back those women who are HPV positive, and then those ones who are negative, we send them an SMS. I mean, just announcing them the results. So sometimes, I mean, we are having issues finding all those who are HPV positive to come back for like for VIA to be able to determine the treatment it is. But also another big issue is that these tests that we're using are expensive. So we are lucky to have the support from CHI, from United, but also as a government, we are looking at those strategies to be able to, to continue providing these services at the end of the grant support. So one of the strategies is to see how we can, is to request our community health insurances to be able to cover also HPV DNA tests. So, and also again, maybe another change that we should continue working on is to make sure that our community is aware. So, continuous education using different strategies. So briefly, that's what I can share as experience of Rwanda. Integrating.
Yeah, thanks, Francois. Affordability seems to be the greatest hurdle to sustaining these services that you're now establishing. Am I right?
Yeah, exactly. Affordability is really probably the main hurdle we have now. So we are lucky that now we have this support from from CHI, free funding from United. But if you look at the test itself, the sample collection tools, so we are lucky to have, let's say, we have the deal, we negotiated maybe a good contract with Abbott. Actually, now we are using Abbott platforms, molecular platforms. So like the cost per women is around $8.60 US. But if you look at the purchase power of our women, of our people, is still high. So meaning that, having this test really, affordable, available at really relatively low cost, it would help us to accelerate the scale up of the program. So, and also the other strategies that we are really exploring is to have our health insurances, able to cover this test for our women, so that because we do have, let's say, the community health insurance that is covering around 90% of our people here in Rwanda. So, having it covering this test and then people paying only 10% of the total cost of maybe those $8.60, that will also help us to really scale up this program to increase the access easily.
It's great to hear that Rwanda is really looking at some sort of universal health coverage approach. But what would you like to see from international organizations, Francois? How can organizations like UICC, like Jhpiego, how can we help improve the chances of success in Rwanda, but also in other countries?
Yeah, I think it's, I would say that we need really to speak one voice, to get together, to join our efforts to make advocacy, because we are seeing that these tests are being manufactured by maybe, I don't know how many companies that we have. So how can we work together? How can UICC and even those other organizations can really maybe be the strong case? They make advocacy to these like pharma companies to be able to, to reduce, significantly the cost of these, this HPV DNA test. Because if, the new recommendations are talking about HPV DNA tests, and then they are really very, very expensive. So there is no way that really we can really achieve these targets that are in the cervical cancer elimination strategy. And also, why not maybe? Because I think it's possible. So we are talking about, I think if you look at those existing platforms, they are those centralized platforms. So can we have point of care HPV DNA test platforms so that the test can be done at the health center? And then, so the woman can come, get tested, and then get the result the same day. And if she needs to be treated, and also do it the same day. That would help a lot to reduce the loss follow-up of those women, calling back again. So these are things that I think things should happen together. I mean, WHO, USS, and also those other organizations, how negotiating really access prices to those pharma companies manufacturing these available HPV, but also invest in those other technologies so that you can have point of care, test technologies. But I mean, artificial intelligence is also being like a promising, let's say, solution, but I think we still need also to see how this test also can also be, the cost can also be reduced.
Yeah, absolutely. Thanks very much, Francois. Let's now move to El Salvador, and I'd like to bring in my good friend Mauricio Maza from Basic Health International. Mauricio, you've been working some time with partners in El Salvador. I'd like you to give us a bit of a perspective on how your work alongside the ministry is really looking at transitioning to new technologies over time, and how you try and consolidate that in the public health services. So I think you have a few slides, so over to you.
Sure. Thank you, Julie. Yeah, it's a real pleasure to be here and share a little about the experience that we've had in El Salvador for a bit. Let me know if you can see my slides. Okay, great. Yeah. So basically, we started working out basically, a decade ago on cervical cancer screening through VIA, which was something that seemed to be very promising, especially for the rural areas in El Salvador. This is how the outreach programs would look like, as even community members would help moving the tanks for the cryo that would be provided. But what we learned fairly soon was that when you would scale, because that's a lot of what we're talking about today. It's like once you needed to scale those services, it was very challenging to maintain the quality and control over providers and actually get to that population level scale, right, through that sort of screening. So what happened around in 2010 was that there was a regional meeting with PAHO, and the Ministry of Health partnered with BHI and many other organizations, NCI, PAHO, UICC, local organizations like the OBGYN Society and Pathology, Cervical Cancer Pathology Societies, and decided to come up with a program that would actually see how we could introduce HPV testing at the time. And that's how we developed CAPE, which is cervical cancer prevention in El Salvador. And it was divided in 3 phases. And of course, because of time, I would go into all the details. But basically what we would do in every phase at a fairly small scale, first we would shoot to screen a couple of thousand women, and we would do an arm where we would do what was innovative at that time, which was doing the screen and treat approach, where we would do primary HPV testing followed by treatment, in our case with cryotherapy. And in the other arm, we would do HPV primary testing followed by colposcopy. And what we saw, we did the first phase, then we did the second phase where we scaled to 8,000. And we did a lot of studies comparing the results of both arms. And what we saw was that it was very cost effective to actually do the screen and treat versus doing the screen and certain to colposcopy, because there would be much higher loss to follow up. So basically, when we got to the third phase where we would do 20,000 women, we knew that the way to go would be do a provider sample collection followed by treatment which would be the visual assessment for treatment, and treat all women that were HPV positive. So that was on the final phase where we scaled to the entire region and that area of El Salvador, and we wanted to reach 20,000 women. So of all the different outcomes, I'm sharing with you like that last one where we had a very high coverage of our goal of 20,000. It was basically 90% that we would reach, and 74.9% of of those women that needed treated got treatment within 6 months. So those were very encouraging numbers for us at the time. And that led to scaling to the different regions in El Salvador. And what you see here, it's basically what you can see is every place where there's a blue dot, that's where we have what we call our triage for treatment centers. And all the dots that you see in purple is where women would come to if they would have a positive HPV result and then would get treated. So sometimes when we talk about this, you know, we don't really discuss all the trainings and education that has to happen. And when we're changing the paradigm, because based on all this evidence, we were able to change the local guidelines, we had to change all the educational material to now include, you know, from what we used for VIA to now including what we would do with an HPV test. And this, talking about scaling, you know, our first trainings for that first phase where you saw that we do a couple of thousand people, this is how large the training would be. You know, there would be a few personnel included, but as we scaled, obviously that became a lot bigger because we needed to reach everyone from the primary level, healthcare promoters, nurses, physicians, everyone that would be actually involved. The same for the lab training. This were the couple of people that were trained for the first time when we did the original first phase. And this is, as you can see on the right, this is how it looks now that this is being scaled to the different parts of the country. And those are the machines that would go to those different labs on different departments of the country. So this is a bigger now training done by the distributor in the country. And the same applies for the treatment arm, where we would train just a few people to do the visual triage and the cryotherapy. And now with the use of new technologies and the use of new models, we're able to also scale that. So that's sort of, you know, what's seen before, like the outcomes, the hundreds of people, thousands of people that need to be trained to actually get to that national coverage level. And as you can see, it was very slow at the beginning when you're sort of testing it out. And then as you roll out, it starts to go fairly quickly, you know, to higher numbers. So this is how we started to work. This is how it looks like. And currently we can, you know, the Ministry of Health El Salvador, it's already procuring the HPV tests. And we hope that this year, the procurement for the whole country on a yearly basis will be done. And that's about 125,000 tests done per year to get to that goal that we all been talking about, which is that 70% coverage of screening. And hopefully we can get to that 90% treatment of all those women that have an abnormal result. So that's our experience here. Thanks
very much, Mauricio. It's really great to see that progression over pretty much about a decade, right? So it's great to see also your sharing of how you've scaled up training and things like that. But what's your learnings about keeping flexible and agile for adopting new tools as the evidence of their value emerges, and of course as affordability for individual countries come forward? How do you deal with that in that partnership that you've presented? You know, when do you decide which new technologies are going to be taken up?
I mean, we're constantly trying to test different technologies. Some work, some definitely, you know, it's complicated. And every time that we see something that comes up, we automatically think of scale, you know, because usually I talk about what's the ideal world versus the practical and the real world. And sometimes some ideas might seem that are good, but if you really think about how is this going to look like when I go from screening 1,000 to 20,000, right? Can this will be something that can be applied? And some things work out, but you know, most of the time you actually need to test them out. You need to, you know, I mean, this is a Ministry of Health program, and we as BHI are their technical collaborators, but all the personnel that's involved, you know, this is a Ministry of Health run program. So what we try to do is sort of just, you know, connect ideas and possibilities and try them out hand in hand with the support with the ministry. And you know, at the end, they are the ones that are going to make the decision of what works and what doesn't work based on the needs and the resources that the country has.
Great, thanks very much, Maurizio, for sharing that great trajectory in El Salvador, and we wish you further luck in continuing that and building your coverage data and, of course, the impact data as well. I now move to Professor Yingling Wu from Malaysia. Yingling, you've been successful in introducing new solutions for screening in Malaysia and really focusing on the client experience to really bring the community into your process. So could you give us a few moments on how you've brought women's perspectives in to shape the ROSE program, and then particularly from our idea today of how we get to scale up services, how have you used the early results from Program ROSE to influence the sort of the hearts, the pockets and the minds of decision makers and funders of your program?
I think for those of you who don't know me, I'm a gynecological oncologist pretending to be a public health person. And really,
I'm doing very well.
I think this whole program started from the perspective of what I saw was happening to women. I think it's having to look after patients of my age and then asking the question, why are they getting cervical cancer? I mean, I trained in the UK, and when I came back to Malaysia, it just surprised me that there were so many women who were younger than me, and I ended up, you know, it was quite difficult. And so the program ROSE started with this question, why are women not getting screened? And then it built on that, and I met collaborators, I met friends, and it came to a point in 2017, I met our friends in Australia, and they said, hey, do you know you can now do self-sampling? Self-sampling? You don't need a speculum. I said, are you sure? So that's how it started. So what were the barriers? And even to come up with the acronym ROSE, removing obstacles to cervical screening. We started to ask the question, what were the obstacles? Cervical cancer was a disease that predominantly affected those who were from the social economical strata that was lower. So every time they took time off for screening, it meant that they would have to give up an opportunity cost of their livelihood. So ROSE was really a solution to empower women, to make sure that the test went to them. So it was a simple solution whereby we allowed women to screen themselves. We didn't require them to come to a facility. We used mobile technology to ensure that we could communicate and get results back to them. Now, the other thing for women who don't access healthcare quite often is the fear and the ability to get to a tertiary care if the screening was abnormal. So ROSE really looked at the pathway of the woman. What does it take to get them to be screened? What does it take to get them to act upon an abnormal screen? And really one of the empowering thing was our friendship with our collaborators in Australia with VCS. I mean, when you first get into the field of self-sampling, there's so many different self-samplers. Which one do you use? So many HPV testing platforms. Which one do you use? And there's so many technologies. What do you do? And really having access to people who've done it before. And I see the community coming together to use all these different validated and proven tools in the local context. And that's what ROSE is. And to be able to tell that story to the funders. I believe at the heart of each one of us, whether it's a doctor or a funder, we want to be part of history. And cervical cancer elimination
is a historical time in our lifetime. You are eliminating a cancer for the very first time, and the tools are there. And what you're doing is engaging with people to say how you can use these tools to really be part of this history, to make a difference in the lives of women who are really the pillars of our society. And that's the story we use, or my team and I, we use when we speak to our funders, when we speak to our collaborators or corporate people, because in every corporation, whether you do science or not, there's always a mother or a woman who knows how painful and embarrassing a pap smear is, and to tell them that 2 tests in your lifetime will protect you from cervical cancer. I think that's a very strong narrative that most of us can use.
Thanks so much, Yinglin. That's really inspirational. I'm just writing in the chat. So who wants Yinglin to come and work on your own strategy? She's so convincing. So are you able to distill it down to very simple messages? And I think that's a strong message to all advocates. Keep it simple, keep it clear, and really try and involve people in what's going to happen. That's great news. And thanks for sharing that, Yinglin. And yeah, one of the things that I think is really important for all of us is how do we get these things funded? And Program Rose is not a government program, right, Yinglin? It's a crowd-funded program.
Yeah, so it started off with Pilot Rose before it became Program Rose, and in the same time now, the Ministry of Health has also started their a phased approach to introduce self-sampling and really to move ground up. Yes, we started off asking the question, what do we need? Malaysia is an upper middle income country, so we're kind of like a middle child. We don't get access to many of the international funds like UNAIDS. So I had to think of ways of how we could get it started. So we asked the question, what do we need to have a pilot program? We needed mobile phones. So I approached a few telcos. We needed swabs. We needed HPV tests. And I think we galvanized together different players to sort of have a demonstration project. And later on, the women spoke for themselves, the experience, we built on that experience, and it just grew. More and more women wanted to have it done. So there were more and more corporations that were prepared to do the funding, to extend the program to the unreached population.
And you mentioned just a moment ago, Yinglin, your partnership with VCS Foundation. How important has that been on the issue of price transparency and knowing what you can aim for when you're doing your own negotiations for the program?
I think that has been critical. That's very important. And I think for any of us who think that we're about to start a pilot program, think about working with someone who's done it before. And I have to say this, our friends in VCS are genuine, are authentic. I remember Marion saying this to me when we first met. We've sorted the issue of Australia. If we are serious about cancer elimination, we need to go to a place where cervical cancer is an issue. And I think that those partnerships are really important. And when we talk about affordability of tests, and for those of us who do laboratory research, you will know that different types of consumables are priced differently in different countries. And so when we approached our local distributors to discuss how much, the pricing of the swabs, pricing of the consumables, we then realized that there's a differential pricing compared to some other countries. And it's in meetings like this, we realize that the processes within the country can cause a wide variation in the prices of consumables. And those are the conversations you need to have with our local distributors to see how we can come to a meeting point, because they are also under different pressures, because different countries have different financing methods or how you bring in consumables.
Thanks very much, Yingling. But I think the core message is get in there and get some experience, because you learn from it, and then you can shape and be stronger in your negotiations next time. So thank you Thank you very much to our panelists. I'm going to hand back to Samesh to introduce our last speaker and share an exciting new project for us as advocates in the cervical cancer elimination space. Over to you, Samesh.
Thank you, Julie. So we heard the theme of affordability of the commodities required for both screening and testing and treatment coming up again and again, and the need for more transparency across pricing. I think about this as asymmetry of information, just not because anybody wants to hide it, but it's just that effort is needed to bring more transparency to the existing costs of the various products that are available in the market. There are a lot of these, so a very basic kind of a tool that can help in this, addressing this asymmetry of information will be very helpful. So I want to introduce my colleague Heather Harrison, who is the Executive Director of Together for Health. She is a great advocate for cervical cancer, and Together for Health is an advocacy organization for cervical cancer, and they're doing some great work in this space. So Heather Harrison is going to share some good news on this front, as we have been discussing on the costing issues for the last 60+ minutes. Over to you, Heather, if you can hear me.
Hi, yeah, I can, Samesh. Thank you so much. And I just want to say on a personal note, I really feel so inspired by the work that's presented across so many of the speakers today. And I just applaud what you're doing at the national level, and certainly the work of WHO colleagues to update the global guidance for screening and treatment. As Samesh mentioned, I'm the Executive Director of Together for Health. For those of you who may not be familiar with our organization, Together is a coalition of civil society organizations and other partners who are focused on fighting cervical cancer in low resource settings. And one of the key components of our work is to promote and disseminate the latest guidance for implementing organizations who are looking to facilitate, so that we can facilitate the transition towards improved technologies for cervical cancer prevention, as we've been talking about today. And next slide, please. As part of this effort, we're excited to share today that we are partnering with you all at Jhpiego and with other organizations to develop and disseminate a costing guide that will outline key characteristics and range of costs for several products. Those include HPV testing platforms and their associated assays, as well as self-sampling products and ablation devices. And we really sincerely hope that the costing guide will contribute to this ongoing dialogue about affordability and promote transparency in costing, recognizing that there is a lot of variation across programs in terms of what programmers need to fall in line with their cancer control objectives. But we're really looking to support the folks who are on the front lines, making program decisions every day about what products they need and want to incorporate into their individual programs. So Samesh and I have already started to reach out to a number of manufacturers, and thanks to those who've already provided information and some details, we'll continue to build out the costing guide over the next several weeks, and we hope to share that with you later in the fall. For anybody who is interested in learning more about this project, please feel free to reach out to myself or to Samesh directly at the contact provided here. And we're happy to include you and would love to get feedback on some of the inputs that we want to provide in terms of the test characteristics and so on. So that's it, maybe just a teaser for today, Samesh, but I want to thank you for your work and helping us move this together so that we can support better coordination and again, promote transparency and affordability as best we can. Thank you.
Thank you, Heather and Heather White. I'm so sorry for I have a colleague which I mixed my head. So thank you so much, Heather, for your leadership, your Tom and everybody together. And this will need everybody's participation because we are just the facilitators of the process. It will need participation from everybody because this is a shared goal and objective, as all of us have been discussing today. So thank you for this very important piece of work. I hand it over back to Maura.
Thank you, Samesh, and thanks to all of the panelists and your great moderation for that last segment. I think it was really wonderful to hear countries' perspectives from Namibia, Nigeria, Rwanda, El Salvador, and Malaysia. So really a wealth of country inputs. And really also wonderful to get an idea of some forthcoming cost guidance and really learn about the cost effectiveness modeling that is underway as well. So thanks to you all. We're coming up on the end of our time today, so I have the pleasure of reintroducing Dr. Grosbeck-Parham to be our closing speaker today. We have a little schedule change. So Dr. Grosbeck, thank you so much for delivering closing remarks. I'm really looking forward to your reflections.
Thank you. Dr. Nono Similela expresses her regrets for not being with us today. So as been said, I've been asked to just say a few words on her behalf. First, I would like to thank the organizers of this virtual conference and UICC and Jhpiego and the facilitators, the panelists, the participants. Thank you so much for just very stimulating and extremely informative talks and a great discussion. So we all know that each year over 600,000 women are diagnosed with cervical cancer and greater than 300 die from cervical cancer, and the numbers are unfortunately increasing. And we hear these numbers all the time, but we all know that these are just not numbers, but people, human beings, women, mothers, women who are mothers, sisters, aunts, grandmothers, school teachers, grocery store clerks, doctors, scientists, telecommunication workers. They're everything, represent all things that any human being can do. But if you look at where the disease has its highest burden, most of these women, or the vast majority of women who are at highest risk, are poverty-stricken and live in very poor areas. Most live and work where healthcare is a sparse commodity, and particularly healthcare that's related to the diagnosis and treatment of cancer. And unfortunately, still in these environments, cancer is, in many instances, cervical cancer is a death sentence. It's detected late, and we know about the paucity of GYN oncologic surgeons, chemotherapy, radiation therapy in these centers. But it's also a place where these women have a significant distrust of what's referred to as Western medicine, where in many instances, illness is defined as a spiritual disease, where they have difficulties returning to clinics for multiple visits. And again, where there's a shortage of healthcare providers, supplies and equipment, let alone databases, systems for Q&A, and health resources, human resources management. However, in spite of all of these shortcomings and negative aspects, in the center of all of this stand frontline healthcare workers who are proudly committed to providing the highest quality of service that they can in these environments. And these are the people that we have to focus on now if we want to eliminate this disease. Right, this really comes at a great time for me to give my reflections, because I'm right now traveling through the country of Zambia, performing a quality assessment, quality control of a program I helped to start 16 years ago with a $25,000 budget. That program is now run by the Zambian government and has been scaled across the country. So I just left a rural province that's sitting on the border of Mozambique and Malawi. It was a 9-hour trip both ways. We came back to Lusaka and we left yesterday morning, and now I'm in a province that's bordering Namibia. And soon we'll be going out to places that border the Congo and Angola. And so I was sitting up in a meeting yesterday, and when these young doctors and these nurses were standing up, introducing themselves, and you know, I'm a pretty hardened individual, and I was sitting in the back of that room, and I was just overcome with joy to the extent that I just broke down in tears and actually could not control myself. And everybody was looking at me saying, "What the hell is going on with that old man back there?" But I saw what could be done. What happened to an idea that was just built out of commitment and love, and what happened when people bought into that idea and expanded that idea. And like I say, even though the shortages are tremendous, still there were these healthcare providers who stood up like they were in an army, just pronouncing proudly with their shoulders held back that I am a cervical cancer provider, I am a LEAP provider, I am this, I am that. It just blew me away. So there's no question in my mind ever, if there ever was a doubt, there's not one now, that this disease can be eliminated. But we have to focus on providing these frontline health providers with what they need, the tools, equipment, and supplies, but also the databases, the patient navigation systems, the procurement systems, the telepathology systems, the artificial intelligence apps, cell phones when they come up. There is no problem that I have seen or heard for which there is not a solution. It exists, it's there. And I think Dr. Yin Lu summed it up when she said, we have to, essentially, she said, we have to work as a broad, united front. We have to come out of our little personal ego-driven silos and drop those things and work as a unit. We have to work as a broad, united front to push this forward and make sure that the providers get what they need. And if we do that, then we can go back to what Dr. Cantrell showed us. Those numbers are going to drop. There's no question. The modelers are correct. So it's there, and the time is now, if there ever was a time. So that's what I would say. Focus on the people who are providing the care, make sure they have what they need, and we stick together no matter what our differences are. You know, we don't have to be uniform in what we do, but we can certainly be unified. And I think if we focus on those two things, I think we will successfully eliminate this disease. Thank you.
Well, Dr. Grossbeck, that was really, really inspiring. I think you can see that folks feel the same in the chats. Really, in conclusion, there's not much more to say. I think the clarion call of the broad united front is something that we can all take from this meeting to inspire us to continue to work together towards these 90, 70, 90 targets. And thanks so much to all of the panelists and participants here today in the active chats. As a reminder for comments and reflections that weren't able to be addressed in this meeting, we'll provide them collated along with the recording of this event today. So thank you everyone for your time and for your great insights, and really looking forward to continuing the conversation at further virtual dialogue series and the World Cancer Leaders Summit this October. So really wonderful. Thanks so much, everyone. Take care.